Okay, so today we're going to talk about Chapter 30, acute periodontal conditions. So what are acute periodontal conditions? Acute conditions have a sudden onset and a rapid progression. They usually are associated with pain. They're not necessarily related to the presence of pre-existing gingivitis or periodontitis. They can be localized or generalized, and they may have systemic manifestations. In other words, they may affect the entire body. So abscesses of the periodontium. So we have an acute infection involving a localized collection of pus within the gingival wall of the periodontal pocket. So we have a periodontal pocket present, and we get some bacteria trapped inside the pocket, and it collects and forms pus. An abscess of the periodontium is circumscribed or confined to a specific site, such as the facial surface of a single tooth. What is separation? Separation, pus, purulence, it's a whitish yellowish exudate consisting primarily of dead neutrophils, bacteria, and cellular debris. So pus contains several different things. It's usually whitish or yellowish in color. Suppuration is the process of forming pus. And precise etiology of abscesses of the periodontium is unknown, but most lesions contain gram-negative anaerobic flora, so they contain some pretty bad bacteria. What are some characteristics of periodontal abscesses? So an acute periodontal abscess usually has a constant localized pain. So difference between acute and chronic is that acute abscesses come on suddenly, and they usually have pain associated with them. Chronic abscesses, on the other hand, come on over time or develop over time, and they usually are painless. So usually a patient does not know they have a chronic periodontal abscess. Or they could get some dull pain, but it's dull enough that they can overlook it. They can have difficulty masticating or chewing. They oftentimes have a bad taste in their mouth. They're circumscribed localized swelling. Oftentimes the swelling a patient will notice, but since it doesn't hurt, they think, well, they can easily ignore it. Possible increase in tooth mobility. So as the pus continues to develop inside the pocket, it can put pressure on the tooth, and it can eat away the bone. Bacteria eats away or destroys the bone and causes some tooth mobility. Loss of alveolar bone not involving the tooth apex. The tooth usually has a vital pulp, meaning the tooth it's not a periapical abscess where it's infected the pulp of the tooth and caused the pulp to die. Elevated body temperature, if it spreads throughout the body, and may develop a sinus tract. So going back a little ways on some of these things, loss of alveolar bone not involving the tooth apex. So if the apex of the tooth is involved, it's usually considered to be what we call a combination abscess. It's a perioendo abscess. So infections running around the periodontal ligament space on the outer part of the root, and it also runs through the apical foramen and up into the pulp of the tooth. If it does that, it's considered the endodontic part of it, which usually causes the pulp to die. It also can cause some stimulation of pain within the pulp. Elevated body temperature may develop a sinus tract. So a sinus tract is, don't think of sinuses like your nose, those kinds of sinuses. A sinus tract is like a pressure relief valve. So the infection or pus starts to build up, and it puts pressure on the bone and the root of the tooth and all the surrounding structures, the gum tissue and everything. And two things are going to happen. Either one, you're going to develop a toothache, or two, the pus is going to have to find some place to drain. And so oftentimes with a periodontal abscess, the pus will drain up the side of the tooth. A periapical abscess, or one where the nerve of the tooth dies and becomes infected, generally will drain out of the out of the tissue where at the apex of the tooth that is infected. A periodontal abscess will oftentimes drain up the periodontal ligament space and out the top. Either way, the pressure is relieved and the patient is able to ignore the abscess. So these are some pictures of abscesses of the periodontium, and you can see how they can get quite large. This picture on the left, again, these are often painless. And this picture on the right, definitely it has a sinus tract, so it's draining. So it's not even, patients may not even notice that. What patients will notice sometimes, depending on where it's located, is they will see this little thing in the tissue and they will ask, why do I have like this pimple on my gum? So this is a picture of an abscess, likely in the furcation area of the second molar. You can see how inflamed and swollen that is. And here's what the radiograph would look like. And you can see the dark circle, or the infected area, is not located at the apex like it would be on a periapical abscess. It's located lateral or to the sides of the roots. The causes of the abscess of the periodontium, number one would be the blockage of the opening of an existing periodontal pocket. So you've got a periodontal pocket, you get something in the periodontal pocket, if like food debris or calculus, it blocks the opening of the pocket, and so the bacteria build up inside the pocket. Forcing a foreign object into the supporting tissues of a tooth. So oftentimes that happens when you're eating. Popcorn is a big culprit for periodontal abscesses. You get those rough popcorn husks and they get stuck inside the pocket. On a shallow pocket, like normal healthy teeth and gums, we've all eaten popcorn and had popcorn get stuck between our teeth or in the pocket or the sulcus area. And you brush and floss and you think you got it all out, and then like the next morning you have a little piece of popcorn husk in your mouth and it was missed. But it will work its way out because the pocket or the sulcus is shallow enough for the popcorn the fluid to kind of flush it out. When you have a 6mm pocket and you get a popcorn husk in there, oftentimes there's not enough fluid flow to flow it up 6mm and out. And so it gets stuck in there and bacteria build up around it and cause an infection or an abscess. Incomplete calculus removal. So when you're doing scaling and replaning and you don't get all of the calculus, the tissue will tighten back around like it's supposed to, but it traps the calculus that has biofilm over it in the pocket. And so then the bacteria will start to grow and they can't escape because the top part of the tissue has already tightened up. And so then it builds up an abscess. There was a procedure we used to do called gross scaling. So a patient would come in and they would have a whole bunch of, they'd be like a Calcode 3 or Calcode 4 with a bunch of calculus buildup. And so we would take a Cavitron and just kind of knock off the big chunks and then have the patient come back to do the fine scaling of the scaling and replaning part of it. What we found would happen a lot of times is the top part of the gingiva would reattach, but it would trap calculus that wasn't knocked off during the gross scaling down in those 6mm pockets. And the bacteria down there would cause an abscess. So we don't recommend or do gross scaling anymore. Comparison between periodontal abscesses and pulpal abscesses. Pulpal abscesses are called periapical abscesses or endodontic abscesses. Those are abscesses that are caused by infection in the pulp of the tooth. So they occur inside the actual tooth, where a periodontal abscess does not. Difference in vitality or the life of the tooth. In a periodontal abscess, the tooth is usually still alive. So in other words, the tooth still has nerve sensation. where in a pulpal abscess it usually is non-vital. And there's different ways that doctors can test the vitality of a tooth. There's something called endo ice that they can put on the tooth, and it's literally like ice, putting ice on a tooth, and the tooth will either respond or it won't. If it's vital, it will respond. If it's non-vital, it won't. I've seen doctors even, one of the offices I worked in, they just took some anesthetic cartridges and froze them, and then they would just take the anesthetic cartridge and hold it on the tooth, the frozen anesthetic cartridge. And if the tooth responded to the ice, then it was still a vital tooth. If it didn't, it was non-vital. The radiographic appearance, usually a periodontal abscess will have an angular defect or a furcation involvement, where a pulpal abscess will have the abscess at the root or the apex of the root. Symptoms, a periodontal abscess is localized, constant pain. That would be an acute abscess. And a pulpal abscess is difficult to localize and can have intermittent pain. So what patients will describe a lot of time is that with a pulpal abscess, like the tooth will give them some discomfort or even some pretty good pain for maybe a few days, and then it stops. And then a month later, all of a sudden it flares up again, and for a few days, and then it stops. Where a periodontal abscess, especially an acute periodontal abscess, will just hurt constantly. A chronic periodontal abscess builds up over time and usually doesn't hurt at all, but it's still localized. So the course of lesion classification, is it acute, is it chronic? An acute abscess has a rapid onset, it's painful, and it does not spontaneously drain. In other words, the pain is coming because there's pressure built up from the pus. A chronic abscess, its onset is slow. It takes time. You may or may not have pain. Usually you may not, or you usually don't, but you may have a little dull ache, but usually no pain. And then there's oftentimes a sinus tract involved with it, or usually. Now you may not see it like you would with a periapical abscess. So those who have worked in dentistry and seen periapical abscesses where you actually have the fistula and you can see the drainage, you may not have that. It may be draining out of the top or the gingival margin because it's draining up the periodontal ligament space and out. So you'd see it radiographically, but may not see anything clinically. The location of the lesion. So a gingival abscess is located at the gingival margin. So these are your three categories of abscesses. Your gingival abscess is limited to the gingival margin or the interdental papilla. Your periodontal affects the deeper structures, and it occurs at a site of pre-existing periodontitis. So gingival abscesses, think of like gingivitis. They are usually found on teeth that do not have disease. Where periodontal, think of periodontitis, patient has to have pre-existing periodontitis. And then a pericoronal abscess involves the tissue around the crown of a partially erupted tooth. It's usually a third molar, but it doesn't have to be. I've seen it on second molars where they just didn't erupt all the way, and a little flap of tissue goes over the occlusal surface. Commonly, third molars will have that, and they'll be like less than halfway erupted, but they'll have a flap of tissue over them, and the flap of tissue can trap bacteria underneath it and cause infection. This is a picture of a gingival abscess. It's limited to the gingival margin or interdental papilla. And you can see how that's pretty, there's no deep pocket associated with it. It's just right at the gingival margin. Periodontal abscess affects deeper structures as well as the gingival margin and occurs at the site of pre-existing periodontitis. So if you look at these pictures, you can see that one is draining pus. Now again, on both of these, this is in the furcation area. and the tooth like kind of on the distal root. If you look at these are not at the apex of the root. They are halfway up or closer to the gingival margin. Radiographically, this one radiographically, you can see it's in the furcation. Pericoronal abscesses, you can see right here, you've got this flap of tissue hanging over this third molar. You can see the infection there. And you can see down here radiographically, the infection is draining on the back side of that tooth. Treatment for gingival and periodontal abscesses, you're going to numb them up. You're going to drain the pus. So when you have, this is an experience you're only going to share with your friends, but you're going to drain the pus. You're going to do some thorough periodontal instrumentation. So in other words, you're going to pretty much root plane that area. You're going to be pretty aggressive with your Cavitron and with your hand scalers. You'll adjust the occlusion if you need to, but that's not usually the case. Prescribe antibiotics and pain medication as needed. Recommend warm saline rinses, saline salt water, and schedule follow-up appointments. So you want to have the patient back to check the area. Since the abscess, especially a chronic periodontal abscess, the patient didn't feel any pain or know that it was there in the first place, you can't really trust the patient to know that it went away because they didn't feel anything in the first place. For pericoronal abscesses, you're going to administer local anesthesia, drain the pus, and instrumentation as well. Irrigate under the operculum, the little piece of tissue that's over the occlusal surface, and prescribe antibiotics and pain medication as needed. Warm saline or warm saltwater rinses will help. And then probably if it's a third molar, it's going to need extraction. Other periodontal conditions, acute periodontal conditions, necrotizing periodontal diseases. We talked earlier about NUG and NUP and necrotizing stomatitis. They're back again. We're going to talk about them again. Distinguishing characteristics are necrosis or dead gingival tissue, gingival cells, ulceration of the epithelium, pseudomembrane, which is that grayish-white layer of necrotic tissue that wipes off, and punched out papilla or cratered papilla. So let's look at necrotizing gingivitis. Again, it's limited to the gingival tissues. It only affects the gingival tissues, hence the term gingivitis. There are other names for it. ANUG or NUG are the ones that you'll hear more commonly. There's an impaired host response associated with necrotizing gingivitis. It's usually brought on because of poor nutrition, fatigue, psychosocial factors, systemic disease, alcohol abuse, drug abuse, or immunosuppressive diseases. So anything like that that can affect the host response is going to cause an exaggerated response to pathogens, bacteria. Responsible bacteria are the really bad ones. There's spirochetes, your fusiforms, and your other anaerobic organisms. Then we've got demographics usually happens in younger people. More stressful lives, poorer nutrition, drug and alcohol abuse, recent history of stress. Stress usually is the culprit to it. And then you factor in other things like poor nutrition, history of smoking, stuff like that. Now, keeping in mind that when people are under a lot of stress, that's when their home care and their nutrition become poor. So they all kind of factor in together. Necrotizing gingivitis, punched out papilla, pseudomembrane. Underneath, when you wipe away the pseudomembrane, is raw connective tissue. And that's where it becomes very painful. Necrotizing gingivitis is very painful. Spontaneous hemorrhaging, so you can touch or press on the gums and they'll bleed. And fetid odor or halitosis, bad breath. Typical treatment, It's done in a few appointments. Basically chlorhexidine rinses and getting the patient to work on their self-care. In other words, they're going to try and do some basic hygiene, but also to eliminate some of the other factors like alcohol and tobacco, try to minimize their stress. You're going to put them on chlorhexidine for a couple of days, maybe some hydrogen peroxide rinses, and wait a few days. And then after a few days, then you're going to do your subgingival instrumentation. You do not want to do a lot of instrumentation when the patient's in a lot of pain. Continue with your home care and self-care instructions, and then make sure that the patient's trying really hard to manage their stress and get enough sleep. Then you're going to have them back for a third appointment about 5 days later. So now we're about 8 days into the initial outbreak. By then you should be able to complete your subgingival instrumentation. If they're still in too much pain, then you need to back up a few steps. You may want to put them on antibiotics, and then you're going to have them come back for a more thorough appointment. And that's your supportive maintenance therapy. So your distinguishing features of necrotizing periodontitis. The most distinguishing is that it affects the deeper structures of the periodontium, including alveolar bone. So again, periodontitis, difference between gingivitis, periodontitis. It affects the deeper tissues. It can be accompanied by the formation of a sequestrum, which are fragments of necrotic alveolar bone. So some of the alveolar bone can actually die off from the bacteria. The treatment is very complex, and you'd refer them to a periodontist. And then you have necrotizing stomatitis. Necrotizing stomatitis is a rare condition. Usually happens with severe immunocompromised patients. A more important one that we're going to talk about is primary herpetic gingivostomatitis. So primary herpetic gingivostomatitis is kind of the primary outbreak of herpetic lesions. It can be a painful oral condition. It usually occurs in infants or children less than 6 years of age, and they may acquire it when kissing a person during adolescence or adulthood. There are two types, herpes simplex virus 1, which is your oral herpes virus, or herpes simplex virus 2, which is the genital herpes virus. The primary herpetic gingivostomatitis is usually caused by the initial infection of this herpes simplex virus 1. So what kinds of symptoms would you expect to see? There are no noticeable clinical signs, and it goes undetected. The initial herpes simplex virus infection produces very severe oral symptoms, though. So here's the spectrum. You can have a mild, you can have a moderate, or you can have it severe. So the mild one is this child just has a vesicle on its tongue. A more moderate one is that this child has several lesions on the labial mucosa. That looks kind of like it would be quite painful for this child. Notice that they're using bare hands to touch it. It's extremely contagious, so you don't want to do that. This child has it so severe it's spread all over their face. If you touch herpes lesions with your bare fingers, you can get them on your fingers. It's called herpetic whitlow. Clinical signs, so it's very contagious and requires careful attention to prevent its spread. During the vesicular or fluid-filled stage is when it's most contagious. So the herpes simplex virus 1 is direct contact through kissing, contact through open sores, or contact with infected saliva. So it's basically passed from mouth to mouth. Can be spread from one part of the body to another, such as from saliva to fingers or to an eye. So if you were to touch an open sore with your bare fingers, you could spread it. It could spread to your fingers or you could spread it then to like your eyes or something. The recommendation from the American Academy of Oral Medicine is how we practice in our clinic. We delay care until the lesion is scabbed over or completely healed, and is prudent for minimizing recurrences and spread of the infection. So we are wearing gloves and using proper PPE, so we are protecting ourselves from the spread, but we can also spread it around the patient when we're touching all over their mouth. If we are touching the fluid-filled lesions. The presence of an infectious HSV lesion orally or periorally can be a reason for deferral of care. So if we have a patient that has a herpetic lesion, we will delay care until it is completely healed over. So primary herpetic gingivostomatitis has a short duration. It resolves in 2 weeks. The virus travels to the trigeminal ganglion where it enters a dormant stage. So once you've had an initial outbreak, the virus stays dormant in your body. The infection does not recur after the initial infection, but it recurs periodically throughout life in the form of herpes labialis, or cold sores on your lips. So when patients have sores on their lips, generally speaking, a canker sore occurs on the inner part of the lips, and the cold sores occur on the outside. Now, that's not a steadfast rule that automatically that's the way it is. Canker sores are ulcerated. So in other words, they usually have a white halo and they dip in the center. Cold sores are round, but they bump out like a pimple. So that's one way to be able to tell them apart. Single or multiple vesicles can form, and the vesicles rupture quickly and form ulcers. So they become ulcerated. But the ulcers of a herpetic lesion look different than the ulcers of a canker sore. Clinical signs, they're usually, they can be painful. Most of the time, a patient will, on the herpes labialis, the cold sores on the lips, the patient will feel like a tingly feeling for a day or two before they actually get the vesicle. Treatment, they're highly contagious. They'll go away on their own in a couple of weeks. So if you have a patient that has a herpetic lesion on their lip or a cold sore on their lip, oftentimes you will ask a patient how long it's been there, and they usually don't know, even though it's right there in front on their lips. So they're kind of guessing at the time. So look at how it looks. Is it still in the vesicle stage? Is it dried up? But either way, we're going to reschedule the patient out about as long as we think it's going to take for it to heal. So if it's already like the vesicle is opened and it's already in the ulcer stage, then probably another week to 10 days is all you're going to need. If it's just coming on and it's still in the like closed vesicle stage, I'd go out 14 days just to be on the safe side. But again, repeating, we don't see patients with herpetic lesions in the clinic.